Today I'm going to talk about something that does not get enough airtime, does not get talked about enough, is not as much of a topic as it should be. And I'm going to talk about it the same way I talk about everything else on my channel, directly, no holds bars. And I'm not going to whisper. Vaginal dryness, girls. Painful sex, recurrent UTIs that nobody and no test can explain, leaking when you sneeze or laugh, low libido looking like it packed up and, left last week, changes in orgasm that nobody warned you about. These are perimenopause symptoms. And they have a clinical name and they are documented in every book that I read. Cross-referenced, dug through, tore apart. And they are undertreated at a staggering rate. Why? Because women are not bringing them up to their providers and they're not asking for help. Why? Probably because it doesn't feel good or safe to do that. But that stops here. The buck stops here. This is episode 12 of the 82 Symptoms series, which, by the way, after reading all the books, it's more than 82 symptoms, but we're going to stick with 82 for now. Today is Genitourinary. I think I'm saying that right. And sexual health category. 8 symptoms, all of them connected to one thing. I'll give you a guess. Estrogen. So here's what is happening in your body and what most people don't know. Your entire lower urogenital tract. Say that twice. Urogenital tract is estrogen-dependent. So when I said there are estrogen receptors all over your body, I wasn't kidding. They're quite literally everywhere. Every part of it. They're in the vagina, they're in the vulva, they're in the urethra, they're in the bladder, they're in your pelvic floor muscles. Estrogen receptors are everywhere. And all of them require estrogen to maintain their structure, their lubrication, their elasticity, and their function. When estrogen declines, all of these tissues begin to change. The vaginal walls become thinner and less elastic. Natural lube decreases. And when I say things like this happens, I should say like natural lubrication can decrease. None of this is hard and fast rule across all women because we're all different. So bear that in mind. Your vaginal pH can become more alkaline and the tissues can become more fragile, more susceptible to irritation, to tearing, and infection. So this collection of changes used to be known as vaginal atrophy. Terrible. The term was replaced with something even easier to say, genitourinary. Symptom. No. Genitourinary Syndrome of Menopause. Or if it's easier, say GSM. Because the old name was both inaccurate and stigmatizing, and I think this new phrase is not a lot better. Let's make it even less talked about. Why? Anyway, okay. Atrophy implies irreversible decline. GSM is treatable. Unlike some other perimenopause symptoms, GSM does not improve on its own over time. It tends to progress, get worse without treatment, which is exactly why talking about it early is important. There are 8 symptoms in this category, all connected to estrogen loss in the lower urogenital tract. Urogenital, meaning urethra, urinary, genital area. Vaginal dryness, loss of lubrication, naturally occurring. Estrogen receptors throughout the vaginal tissue require a steady supply of estrogen to maintain moisture. So even if you're not turned on or wanting to have sex, etc., you still need natural lubrication. And when you don't have it, you notice it. And when that supply of estrogen becomes inconsistent, the tissue dries. And this can cause discomfort. Feels like sand in your pants. Or it can. Even when you're not having sex, it can be uncomfortable. Just everyday life. Painful sex, which also has a hard to say name, dyspareunia. I have 2 master's degrees and I'm sucking at these words, is the clinical term, aka discomfort or pain during intercourse due to thinning tissues and pH changes. And this is often very underreported as a perimenopause symptom because women blame themselves. Why wouldn't we? Blame their relationship, blame their stress levels. It's none of those things. It's tissue. And this is your permission slip to name it as well. I have been struggling drastically with the desire to have sex because I don't have I don't have the desire. And that's something because I used to be very sexual, like maybe even hypersexual. And now I'm like, changes in orgasm, decrease in sensitivity, altered sensations, and difficulty achieving orgasm. Blood flow to genital tissue decreases as estrogen declines. Can you figure out how important estrogen is? The nerve endings that support sexual sensation are estrogen dependent. This is not psychological, this is physiological. Low libido, declining interest in sex linked to testosterone decline. Fatigue, mood changes, and the physical discomfort of GSM itself. When sex hurts, you, guess what? Stop wanting it. This isn't about a relationship problem. This is a pain avoidance response. Urinary incontinence, stress incontinence, leaking when you sneeze, cough, laugh, or exercise. It's caused by pelvic floor urethral tissue changes as estrogen declines. This affects quality of life significantly and barely gets mentioned. Recurrent UTIs. Vaginal pH becomes more alkaline and estrogen drops. That shift in pH makes the entire GSM tract, tract, more susceptible to bacterial overgrowth. Women getting UTI after UTI in perimenopause are rarely told the root cause of this is hormonal. Vaginal itching and irritation, tissue thinning, and pH changes cause chronic irritation, even without infection. And it gets treated as a yeast infection repeatedly when the actual driver is estrogen loss. I suffered through this for years and not a single provider. And I saw some people who were specialized. Nobody got it. And I was miserable. Pelvic floor weakness. The structural integrity of the pelvic floor tissues depends on estrogen. Their decline contributes to prolapse risk and worsening incontinence over time. Ain't nobody got time for that. And the root cause here is estrogen loss in the tissues of the lower urogenital tract. All 8 symptoms trace back to the same place. And the important thing to understand is that this is a local tissue issue as much as it is a systemic one, meaning you can treat it. You can treat it topically, locally, with topical estrogen, applied directly to the vaginal tissue without the same systemic exposure as full hormone replacement therapy. This makes it accessible to women who may not be candidates for a systemic HRT or who are not ready for the conversation yet. It also means that women who are on systemic HRT may still need local vaginal estrogen because the systemic dose is not always enough to fully address the local tissue changes. Trust me, I got on some estradiol as soon as I learned this because vaginal atrophy, that's fucking shits for the birds. Even if I don't have a libido right now, I am not copacetic with that stuff disappearing. My mom's a nurse, or was a nurse, and she's 17 years older than me. She had me as a teenager. She became a nurse. I recently, in the last 6 months, sat with her and was like, yeah, did you know? And she's like, no. I guess it'd make a lot of sense as to why all the elderly women, when we would try to catheterize, never had labia. We just thought it was generational. This is the moment where you say, the more you know. I don't know why I hadn't thought of bringing this out to show you, but this is the estradiol vaginal cream. It comes with an applicator. It's just bulky. So take it, put it on my finger, insert it in my vagina. We can discuss this in the next video where it's specifically on HRT on how to do this and where to go with it. This is what I use for that. I don't have an estrogen patch. Progesterone. Oral progesterone looks like this. This is 200 milligrams, which is what I take at night, every night. And then my testosterone. And they look like, oh, this is a different one. They look like this. And I use 1/10 of this every day on the back of my calf or on my forearm. That's what it looks like. So topical vaginal estrogen is the most effective and evidence-based backed treatment for GSM. You can get it as a cream like this. You can get it in a ring. You can get it in a tablet to insert vaginally. Systemic absorption is minimal, and it's considered safe even for women with a history of estrogen-sensitive cancers. Though that conversation always needs to happen with your provider. It takes time, usually 6 to 12 weeks, to see meaningful tissue restoration, and consistency matters. Non-hormonal options, vaginal moisturizers, which are not the same thing as lubrication. Moisturizers are used regularly, not just during sex, and they help maintain vaginal tissue hydration. Replens is one commonly cited brand. You want to look for a pH balanced and non-irritating formula, which I feel like is a very obvious thing to say. Lubricants during sex. Silicone-based or water-based, oil-based can degrade condoms if you use condoms and disrupt vaginal pH. This does not treat the underlying issue, but it can significantly reduce discomfort in the short term. Ospemifene, Ospemifene, is a non-estrogen prescription oral medication that's approved specifically for painful sex due to GSM, which is an option for women who cannot or prefer not to use estrogen. Next is pelvic floor PT, physical therapy. It's one of the most underutilized and most effective interventions for incontinence, pelvic pain, sexual dysfunction in perimenopause. If you have access to it, it's worth pursuing. Now for libido, testosterone. Low-dose testosterone has evidence for improving libido in women. In perimenopause and postmenopause, it's often not discussed or offered. It is part of the treatment options episode conversation, so more to come. As I'm sure you know, these symptoms affect the quality of life. They can affect your relationship, they can affect how you feel in your own body, and the best part, they're treatable. The reason that so many women are living with untreated GSM is not that there aren't options, it's that nobody told them the conversation was available to have. So many of us still go to the doctor and feel like we can't actually say what's going on and advocate for ourselves. And I'm so sorry. And I'm here to advocate with you, for you. So I'm telling you now, the conversation's available. Find a provider who will have it with you. I finally found one. It took me 15 years. I found one. Next episode, favorite episode, besides this one, because sex is important, we're going to our gut, the digestive symptoms of perimenopause, and why your GI tract is a hormone organ that most people have never been taught about. I know I didn't know, and it sure would have saved me. And as always, nothing I share here is medical advice. I'm a coach, I'm a holistic nutrition student, and a woman living through this in real time. Do your own research, be your own best advocate, find a provider who listens, and if you walk in and somebody doesn't listen, walk out. Be your own best advocate. Fuck them. We don't have time for this. And as always, take what resonates, leave what doesn't, and if you haven't done something to love yourself today, girl, please go do that. And if you don't know what that looks like, message me, drop me a DM, whatever. I'll help you figure something out. All my love until next time.